but sometimes it's really small things. And it just, trust, I was told, is gained in droplets and lost in buckets. So it's every little drop that we can gain matters, and that's our approach.
Well, everyone, I'm sorry, we've got a hard stop right now at the 2:30, but I encourage you to follow up with the panelists offline or through the email as well.
Yeah, it all worked out,
I'm here to take you out now. Okay. This is about
so close to having this right.
The weird thing is, like, I've talked to every We're a social media savvy group. Once Peter, once Peter doesn't have this.
So I've got a couple extra inches there and more of that.
Pull up your back up.
Not just sort of pitching the website, hopefully it'll all work out.
And I'm going to go down now.
5 different ones. The other way.
Yes.
I'm very impressed.
Oh, you got it? You got it here. Okay. Okay,
I got one. You got one. You got one.
let's see, we're going to 35, we got 50 minutes from the time you start. So let's say if you start at 6:30 this morning, you did it. Congratulations. Okay, well, we're taking 2:35, so you have 50 minutes from now.
Ready to go?
Yep.
Ready to go? Sounds good. All right, Jim, I want to thank you for the invitation. My family's very proud. This is the closest I've ever come to being accepted to Yale. So I really appreciate the opportunity. We're going to do a really quick poll. We were just doing this outside. There's absolutely no relevance to this session, but I just think it's fun. We're trying to assess people's fears and whether you're more afraid of sharks or snakes. So who's more afraid of sharks? Let's raise their hands. And who's more afraid of snakes? Raise their hands. Wow. And anybody that would put snapping turtles at the top of the list? Oh, look, I said you're going to have one or two. All right, great. So I really appreciate the opportunity. My name's Jon Stout. I'm a partner at Optum Ventures. We're the venture capital arm of United Health Group. But I'm humbled to be here with this group. I think we're going to have a lot of fun, a lot of interesting conversations. I know the last panel said that they were going to be the best one of the day, but I'm pretty sure we're going to be better. My experience with these things is often we wait till the end for questions. But I would encourage you, if somebody says something that you have a question on or want to follow up on, please raise your hand, and I'm going to do my best to kind of spot that and pull the question out in real time. I have a PhD in clock management, so I'll make sure we're out of here at the right time and kind of manage the agenda. So please, let's make it interactive throughout. I'm not going to go through and introduce everybody. I'm going to have them do that each themselves, kind of who they are, what they're working on, and I think you're really going to be impressed with this group. So Jess, we'll start with you.
Hi, can you hear me?
Yes.
Wonderful. Very honored to be here today, and thank you, John, for the invitation, and for Yale for hosting. I'm Dr. Jessica Gaulton. I'm a practicing neonatologist at Harvard. I'm also CEO and founder at Family Well Health. The reason I started Family Well Health is because I struggled with postpartum depression myself as a physician and a mom of two. And our healthcare systems are broken in terms of the lack of support for new parents. And so Family Well Health, we provide integrated behavioral health services in OB clinics to support new moms and hopefully new dads and partners someday. Thank you.
Hello, my name is Daniel Etra. I'm co-founder and CEO of Rethink First. I was here this weekend for my 30th Yale reunion, so I was telling John I wish he scheduled this yesterday so I could have made it a 4-day weekend. But anyway, Rethink First, we're a global behavioral health technology company. We are the mission-critical software that school systems, employers, behavioral health providers, and health plans use to manage high-needs populations. So think about conditions like autism, developmental disabilities, mental health issues. We automate everything from the staff training, the intervention planning, the data tracking and reporting. And we use precision AI to target the intervention to the individual. And now we're starting to be able to predict outcomes for these populations, something that wasn't possible previously. We work with 8 of the top 10 public school districts in the country, a third of the Fortune 100 on a global basis, thousands of provider groups, and some of the largest health plans in the country, including Trips.
Hi, everybody. Can you hear me? Yes. Okay, cool. My name is Sofia, and I am a psychiatrist by training. I'm also the co-founder and CEO of Nima Health, which is a venture-backed startup that focuses on providing high-quality treatment to survivors of trauma and post-traumatic stress disorder. It's also something that's near and dear to my heart as well. My family survived the Vietnam War and were refugees to this country, and I also, unfortunately, was diagnosed with PTSD and served as a rape crisis counselor before becoming a clinician. We also work with Trip and John, working with payers to make sure that patients can access the treatment that we provide.
Thank you.
Good afternoon, everyone. Trip Hofer. I am currently the CEO of Optum Behavioral Health Services. Prior to this, when I knew Jon I worked for a startup called Able To. This is my third startup, and I now am working for a behemoth, which has been interesting. We'll talk about this later. But I want to just pause and just thank everyone for this conversation. So Josh Jabal, he's not here. Good friend of mine. I went to SOM, by the way. I graduated in 2002. Different building, by the way, small building. This is a beautiful campus. But I really applaud all of us getting together today to talk about mental health, because it's a huge issue. And the fact that we're talking about this, if I reflect back 10 years ago, we didn't talk about mental health. But the fact that we're talking about it, so I applaud all of you for being here today and talking about it and endorsing the fact that it's not bad to talk about mental health. Mental health is a condition that we need to talk about more and more. So if nothing else, I just want to thank you all for being here today to talk about mental health.
Great. So we'll jump right in. And Trip is super humble, kind of walk through what he does now. I don't know that this group would have an appreciation for Optum Behavioral Health Services being the largest behavioral health company in the world. And probably no individual can have or has a tougher job, but at the same time more ability to have impact in how behavioral health is managed and paid for and transformed. So appreciate you being here and appreciate this entire group. As Trip mentioned, he was my boss for several years, and he was CEO. I was head of growth for a startup, so I've got a lot of really fun road trip stories. If you're looking for leverage, we can talk. But Trip, I'm gonna jump to you first, and I'm assuming level of expertise in the mental health space in this room is relatively novice. And I think sometimes when I'm talking to people who are experts in healthcare but haven't really thought a lot about mental health, there's just a lot of differences in serving the mental health population versus the general physical health. Trip, maybe you can just start with what are some of those differences and how is it different running a mental health company as opposed to a traditional physical health company?
Yeah, I appreciate that. And so I'll start the dialogue. I'll be brief, but I'll start the dialogue in 2010 when I was at Optum. So this is my second stint at Optum. I was there. I went to a startup after business school here, SOM, and then I went to Optum. Then I went to CVS, and then I went to a startup, and then I went to Optum. So it's my second stint. And in 2010, no one cared about mental health. And when I say that, I reflect back. Practitioners in the room, I apologize because I know you care, right? But most people did not care about mental health, and here's the reason. So $100 of spend, of medical spend, $95, and by the way, it still exists today, is physical health, and $5 is mental health. So when I would talk to payers, and this is, by the way, health plans, government, employers, they would say, Trip, I get your passion, but the reality is, if I reduce my spend by 10%, right, do I focus on the $5, which is mental health, 50 cents, or do I focus on the $95 of physical health? And it's a no-brainer from an economic discussion, right? And so what they didn't appreciate then, and we appreciate now, is that 45% of that $95 is actually influenced by the brain. And when Jon and I were able to, we had the chief medical officer of United Health Group come. He was my mentor, my first stint. He came and spoke to us in New York. And he said something profound, but I call it a dumb moment, right? And what he said was, he said, God never intended the head to be divorced from the body, but that's how we deal with mental health. The body's over here, and the head's over here. It's about time we start to do it this way. And I can't tell you how profound that statement was from him to think about that, right? There is no reason why we should not support the mind and the body at the same time. But that's, what we've done. And so, coming from physical health 10 years ago and coming over to mental health now, I think it's about time we talk about this stuff. I have 3 kids. They all see therapists. I see a therapist. My wife sees a therapist. I won't even ask you all in a room, how many people have been impacted by mental health in this room. I guarantee you, if I ask you to raise your hand, you all raise your hand, either a friend, family member, someone. But the reality is that 10 years ago, we didn't talk about this stuff. And so I'm very excited that we're actually talking about this stuff now. And if we compare it to 10 years ago, the amount of investment and money that's coming into mental health is amazing. So I'm excited about this time and these panelists. I know most of them personally, and they're doing amazing things. But it's about time that we started focusing on mental health.
Great. Thanks, Trip. And I think, Sofia, I'm going to look to you next. when thinking about back to your early time and back to our parents and how they might think about mental health and how we think about it, I think generally speaking, especially with an audience that looks like this, there's a wide belief that stigma has like drastically come down. And like we're open about it, we're talking about the fact we're here. I think that's wonderful. But I think stigma is still a really big deal. Like it's no big deal to tell your boss, hey, I have to leave early to go to my cardiologist. Right? But most people still feel weird saying, hey, I have to leave early to go to my psychiatrist, right? And Sofia, I think in what Nima's doing, specifically in the PTSD space, how do you think about stigma? How do you think about getting people past that hurdle and ready to embrace new treatment options?
Thanks for that question, John. I think obviously there's still stigma in mental health care, right? And I think what breaks stigma is like transparency and like awareness, right? And sharing and communication. And I think it starts with like, for people who feel ready to do that, sometimes disclosure, sharing your own story. And that's one thing I really admired, Jess, for you sharing your own story too in your intro as well. Because I think all of mental health is really stigmatized, and then there's pieces that are even more stigmatized, right? Like trauma is definitely one of them, postpartum depression, things like that. And so I think sometimes it's even more important to share and to provide as much awareness as possible. I think also stigma becomes an issue too when you're selling as well, because these are things that people don't necessarily think about. So there's like a lot of education that you have to do with like in the sales cycle as well, to just make sure that everyone kind of understands how insidious some of these issues are. And I think that can be really tough, right? I think also as a clinician and somebody who's building a care model, I think the flip side of stigma is privacy, right? Like I think there's a line to walk there as well, like that you want to make sure that you're also providing like a private experience for folks, but then also like reflecting back what parts where they could get more support to kind of break down stigma when that's the reason they want privacy. Does that make sense? Like when community is actually needed and they're just afraid of reaching out for that. Does that make any sense? So I don't know. I think there's like lots of layers to that question. I'm just going to stop there.
Any questions so far? I'm just going to scan the group. Oh, sure.
I have a question about any changes that you guys have seen since the pandemic in mental health, because I know, of course, percentages of mental health crises went up during the pandemic. What changes have been made in terms of stigma?
Who wants to start? Go ahead, Daniel.
Sure. So I think, from the employer perspective, one of our biggest end markets, I think building up pre-COVID, I think to Trip's point, there's a greater awareness of the need to support the mental health of employees. And it used to be, I remember when we started the company back in 2007, 2008, you talked to an employer and you mentioned the word mental health and they had no idea what you were talking about. And it was musculoskeletal, it was diabetes, it was cardiac disease, everything above that. And I think you've seen sort of a trend building pre-COVID and then accelerated during COVID, where employers, as self-insured plans, recognize that they have to address the mental health needs of their employees. And I 100% agree with Trip. It's done in combination with acute care, chronic disease management. That mental health piece is critical. The other side of it as well is recognizing that certainly for employee caregivers, if you have a dependent with a developmental disability or a mental health issue, that's going to drive your own mental health needs as well, and that these things need to be addressed in tandem, not in a siloed manner, direct to patient. So it's not just you're serving that dependent with telepsychiatry and you're serving the caregiver with telepsychiatry potentially as well. You need to understand that the challenges that employee caregiver is facing, in the most part, in certain cases, is due to the needs of their dependents. So you have to provide the right kinds of caregiver supports in addition to a lot of the services that are being provided traditionally, and then also scalability. I think telehealth, I think we all recognize that's now ubiquitous. I think employees are more comfortable being able to access the healthcare in the way that they like, and so making those services available, working with the firms that build out networks so that any time that you as an employee need access to care, you can get it.
Sure. Were you going to add something?
Yeah. So I'll give you two data points. So the first is if you look at the use of telehealth for behavioral has gone like this, and medical has gone like this and like that. right? So medicals come back to physical, right, back in locations. Behaviorals continue to use telehealth at an enormous rate, which is fantastic. I will also say this, and I learned this in a presentation the other day. So if you look back in there was a fascinating article in the New York Times about 6 months ago, which if you look back every decade, there's been some kind of an event. World War II, World War I, Vietnam War, whatever, right? The difference though right now is the phone. And it's the phone. And it's the use of the telephone and the fact that how much impact that has on our kids and us as adults. I was at I share things I shouldn't share, but I was at a dinner party the other night with a woman. She's 25, and she's she looked on her phone, and all her friends are at a party on Instagram, and she's not there. And she sunk into a mass depression. That did not happen 10 years ago. That didn't happen 20 years ago. So the pandemic, yes, but it's also the advent of the phone and the fact that you can see what's going on with you and your friends. It's very scary. And so we also have to think about that. But again, what I'm really excited about is I think this sounds bad, but the pandemic accelerated telehealth for behavioral. I think we'd all agree to an enormous amount that thank goodness. I'll let you. Sorry.
Jess, anything to add or move on? Okay. Daniel, I'm going to come back to you. And I've learned a lot about the autism space over the last couple of years. And maybe a two-part question. One, just curious, you guys have been at this for a while now. What made you focus primarily in autism care when you guys got started? And then I was at an autism-focused event a month or so ago, and one of the speakers said something that clicked for me, was that we talk about autism care today the way we talked about cancer care 50 years ago. And what he meant by that is 50 years ago, if you had cancer, you had cancer. You didn't have a specific type of cancer, you had cancer. And there were very limited treatment options. Everybody was kind of treated the same with those blunt force objects. And that kind of feels like autism today, and it's exciting to think about how we might treat autism going forward. So maybe a little bit of what made you see this 15 years ago, and how do you think about that comment?
Sure. So I've done a variety of things, and most of them not healthcare related. But starting this venture, it was really business school classmates of mine that were coming to me, and friends and colleagues who were saying they were having their kids diagnosed with autism, and they talk about how hard it was to find services, let alone be able to pay for them. And this is back in 2006, so we would say pre-appearance on Oprah. No one really knew what autism was, but from a purely market-driven perspective, very, very clear population, very, very clear treatment methodology, behavioral intervention, and a very clear problem in the marketplace, which still exists today, a dearth of trained clinicians available to meet this demand. And so we thought, how can we leverage technology to really drive scale? And the nice thing is, to your point, I think we were very fortunate to enter this space when the wave was really starting to build, so that by the time, look at where we are today, autism has every PE firm, venture capital firm looking at investing. I think there's a real awareness in the healthcare system of the need to cover behavioral intervention. And so I think we're in the right place at the right time. Second part of the question, I think the biggest differentiator for us and the opportunity for us is the use of data to drive intervention and to be able to predict outcomes. If you look at the conditions like cancer, diabetes, cardiac disease, based on, let's say, cancer, the diagnosis, very clear what is the treatment protocol, level of metastasization, et cetera. What's the likely outcome? You take a patient with an autism diagnosis, or two identical patients, seemingly identical, you have no way to predict today what that likely outcome trajectory looks like. And the reason is the data hasn't existed. And you have this unusual dynamic in the marketplace where it's the provider, the entity that's actually delivering the services, that's doing the prescription for the health plan. And so we see a tremendous opportunity to leverage outcomes data to start to predict what that outcome trajectory should look like. And I get excited. In our company, I think we have almost 500 million clinical outcome data points that we've gathered in the years since we've been in business, and we're now deploying AI to start to predict with a super high level of accuracy. I think we're up to like 99%. What should that outcome trajectory look like? And that's where you start really bring precision medicine to this population. It's not just up to that provider essentially saying, this child needs 30 hours a week, this child needs 40 hours a week in these areas. No, there's a clear clinically recommended intervention plan, and then based on predicting or being able to see what that trajectory should look like, being able to assess, is that provider delivering on those services or not? Think about how do you identify centers of excellence from a health plan perspective. At what point do you begin to titrate care? Is this medically necessary or not? And also, what's the appropriate level of care? Sometimes it's the provider that's under-prescribing as well. So we see a real revolution coming in deploying the outcomes data to be able to predict what that patient trajectory should look like and bring a much higher level of precision to the way care is being delivered.
That's great. One of the things that's always been a helpful visual for me in thinking that way and in really thinking about what each of your companies are doing is most care in mental health for the last however many years, 100 years, has been this kind of black box where you don't really know what you're going to get. There's no transparency in terms of outcomes or treatment. And what companies like Rethink and others are doing is trying to take that black box and break it up and turn it into Legos. Right, where you can actually plan and visualize what's going to happen and predict with some reasonable certainty what it's going to look like on the other side, which in turn gets the payer happy to work with you, right, because they can predict with greater certainty what it's going to cost and what those outcomes will look like. Jess, I'm going to turn to you now, and we've been talking really since the very beginning, and specific to FamilyWell, how do you think about outcomes? Like, what is it important for you to be tracking progress for, to understand that, yes, your clinical programs are working and that they're also creating value for payers and other health plan organizations? So how do you think about that?
Yeah, so I love this question because in addition to the value of data for payers, for predictive analytics, for AI, data is gold for providers and for predicting, guiding, helping clinicians make decisions for their patients. And so stepping back just a second, how many of you have heard of value-based care, have studied it, have interactions with it? Okay, we've been talking about value for how many decades now? And I've always wondered, I took Michael Porter's class at Harvard Business School 2 decades ago, and I was like, oh yeah, this is the future of healthcare, this is it, we're gonna do this, and 2 decades later, I'm like, where's value? It's just starting. And I wanna break it down for you because I think value-based care is simply an equation, right? So the numerator is improving clinical outcomes and the denominator is lowering costs. That's value. And the way at FamilyWell, the way that we center our clinical care is based on value because that's good for everybody, right? So measurement-based care at FamilyWell means using our data. So we're doing mental health screenings regularly for our clinicians to make decisions about what's best for their patients. So that's the numerator, right? And then we're constantly tracking cost data as well. And because we as a society, I think we all are aligned, I can't say all, but many of us are aligned on the idea that we're spending too much money on healthcare, right? And so we need to get more efficient. We need to make better clinical decisions using data, and we need to lower the cost of care.
Anybody else? Any questions so far? Sure.
So you started with the cancer as 50 years ago. So one of the reasons why cancer is still now manageable is because investments that went into early detection of cancer. So that allowed us to predict disease. It allowed us to develop medications and follow. So one of the things that I've always wondered is, are there diagnostics that can be developed for early detection of mental health? And that's a question to the panel, because if you can, just like cancer, detect mental health early, and you see the signs early, because the signs are there, we miss it as parents, we miss it as friends. How do you measure that, and how do you actually use that as a data point to predict that this person is going to have some issue and actually have the line of treatment early rather than later? We have been talking only about aftercare. I'm trying to go a little bit upstream.
I can start. Anybody want to jump in? Trip? No?
Okay.
So it's 100% yes, that the data and technology is there to be able to predict who are those folks. We used to, in one of our go-to-market stories, had a curve, right, where you kind of plot people along the complexities of mental health needs, and we could predict with reasonable certainty who are the folks that are going to intervene and move upstream and ultimately become the severe mental illness population. And then at the same time, there are treatments that work for that population. And it's the classic story of, like, how do we intervene and get those folks better before they move up the curve? Like, 100% that can happen, and that can happen today. Sadly, it comes back to reimbursement, right? And I think that's a big part of it is, okay, you're kind of proving a negative, and it's hard to sell a service if I'm saying, hey, trust me, this individual, if we don't intervene, 5 years from now is going to be out on the street and schizophrenic and going to the emergency room 300 times a year. We want to intervene now. We might all know intellectually that's the right thing to do, but actually figuring out the reimbursement pathways for that is really, really hard. I tell this story. It's not related to mental health, but a pediatrician who managed a really large pediatric group said to me one time, back when I used to work at a health plan, he said, how do you create incentives for me to treat fat kids? Right? Like, those are his exact words. And what he was saying is, when I have an obese child come in my office, I obviously know what the right thing to do is, but because you aren't reimbursing me to manage the obesity, I'm just treating the sinus infection and getting them out the door, right? And I think there's a lot of similar trends kind of in the mental health space where we know what the right thing to do is, just the reimbursement hasn't caught up yet. Any other?
No, I'll just add, I think it's not just the responsibility of the healthcare system, it's also the responsibility of our education system as well. And I think you see, to your point exactly, suicide rates are skyrocketing to a shocking level within our public school and private school system. And the idea is we feel you should be deploying the right kinds of mental health supports at a very early age within the school system for all students so that you catch those that would normally fall through the cracks. And to your point exactly, you're not waiting for the healthcare system to pick up the slack in their curricula like social emotional learning, which unfortunately is receiving backlash in certain parts of the country. But these are basic approaches to identifying and addressing issues of stress, anxiety, depression, mitigating bullying, mitigating school shootings. I think it's a universal responsibility, and certainly the education system should bear a big part of that.
Any other questions? Sure.
So my question is related to what Jessica just said. I think data affects both the outcome of the patient, also drives up, affects the cost of the service. Thank you. So data affects both the outcome as well as the cost of that service. But if you are not specific about the quality of the data, I think we're going to always struggle with that ratio you talked about. So I think going back to the point that was raised, one of the reasons why cancer is now able to be treated is because of the specificity of the disorder. So can anyone in the panel, or at least one of you, speak to the specificity of the treatments?
So something that I believe very strongly is in evidence-based medicine and evidence-based behavioral health care. And so what that means is there are a lot of interventions out there, especially in behavioral health, and I'm not a behavioral health clinician by training, but coming into this and learning a lot on my own, like you said, the quality of data is so key, especially very particularly important to make clinical decisions. Unfortunately, we don't have the best mental health screening modalities in perinatal behavioral health, a field that we're pioneering, but we truly believe in refining this over time. So you have to start somewhere. You have to start with the evidence-based tools that you have, and then over time we improve upon them as we collect more data. And importantly, having academic partners. So I am an academic clinician, but I partner with other academic clinicians at Harvard to study our intervention. It's a little tricky doing both, and I have to, there's a line, and if anyone wants to talk about how to do that, feel free to talk to me. But it's really important to have academic partners who are studying your intervention in an unbiased way to be able to further refine the impact that you're making in your field.
So what I'll say is, to both questions, by the way, let's talk for like 5 hours about this, because this is it right here, right? So if I have high blood pressure, what do? Right? I take blood. If I have cancer, what do? Like I take you can't take something out of the brain. This is the problem. And so we have to rely on basically self-reported evidence of someone saying, I feel better about that treatment. And the data is horrible. Be very specific. 95%, so my network at United Healthcare, 365,000 people, 94% are what we call single shingles, which means they basically have there's no network. And like I rely on them to send me data. There's no data. So I'm like, please send me anything so I can hopefully assess if your self-reported data for your patient is any good. This is just where we are in mental health, but I totally agree with you. We got to start somewhere. So I'm being a pessimist but an optimist, right? We got to start somewhere, right? But it's a hard space to figure out, like, is that good care? Right? My daughter, and I tell the story, John knows the story. My 15-year-old daughter went to a psychiatrist in Newton, Mass. Newton, Mass is very affluent, for folks who know this area, right? And she's like, I know CBT, which is cognitive behavioral therapy. I practice it. I'm the only good one in the entire area. And I sat there, I was like, okay, I'm not going to say anything. She had no computer. She had no iPad. She was working off of, literally pen and paper. And she's like, I was like, how long does this last for? She goes, forever. And as John knows, it's 8 to 16 weeks is CBT. Practice well, but forever. And I said to my wife, I'm like, honey, how do you know this is a good practitioner? And she goes, well, it's my friends. My friends say it to me. And I was like, so I started going off on her. She's like, just shut the F up and get in the car, maybe go home. But that's the reality of what we face in this industry, right? And also in this industry, which we've not talked about yet, is not only lack of data, but the lack that if you don't want to take insurance, you just go start charging cash. And this industry, you can make a healthy living charging cash, right? And not take insurance. And so I can't agree enough, though, like what you just said. We've got to start somewhere and try to grab as much data as we can to try and get insurers, practitioners on insurance, because I don't know how else to deal with the phenomenon of our supply issues.
Can I just add something really quick before the next question? So, I have lots of thoughts about this as a psychiatrist as well. If we just take a step back and think about illnesses, right? And just health in general, right? You have prevention, you have screening, you have diagnosis, and then you have treatment, right? And I think in a lot of other, in physical health, that's very easily understood. And even still in the American healthcare system, we talk about it as being Swiss cheese. I think in the American mental healthcare system is like a fishnet. Things are just going straight through it. It's not catching a lot, right? It doesn't work that well for most people, I would say, right? And it's because every single one of those pieces, prevention, screening, treatment, diagnosis, right, are not great. And because we've so underinvested in mental health for a lot of reasons, including stigma, right? And so what ends up happening is when you think about screening, there are some conditions where actually screening is really good, right? And then even if you, then the problem is, like, let's say you screen somebody, well, what are you going to do for that patient if there's no good treatments, right? So then, the classic refrain for a physician is like, well, why would I test somebody for that if I'm not going to do anything about it, right? Then you're just wasting healthcare dollars, right? And so I think it's like a really nuanced discussion to have, because I think a lot of people, want to say like, okay, if we just had better diagnostics, that would fix everything. And it's really not that, because there's so much that's getting lost in every single one of those phases. And it's actually really difficult to find, but also very exciting to find areas where actually, the pieces in the screening, the diagnosis, and the treatment align. And that's where you have a care model and a business model and a company, right? And so I think that's where the magic is, because there are places where that's happening, and there now is more financing going into mental health. But again, it's those things have to align for you to have a business model and a care model that works.
You guys have a question back there?
Based on this conversation, I'd love to get your input on why Pear failed them. They had tons of data, a lot of clinical evidence. We're, commercializing. I'm trying to figure it out. I don't know why they failed.
Yeah, I'm happy to start, and
I can give my pitch.
it's probably a long conversation. To me, I sum it up to distribution, and I think that's a big challenge. And I meet so many entrepreneurs who are so excited because they have a contract and what they view as a pathway to reimbursement, and it's, hey, we have FDA approval and look how amazing it is, or we've got a payer contract and I'm now in network, and it's like, okay, great, how are you going to get that last step of getting the tool in the hands of the patients? And those types of tools require those single shingle docs to do things differently, and that's really hard, right? That's really hard. And so that's why I don't think we've seen anything really scale in that space. What would you add to that, Trip?
Yeah, so I think, I liken this back to when I was in my first stint at Optum, when I was in the wellness space 10 years ago, right? Think about Castlight and all these other companies, did a great job, whatever. But they came and they went, right? And that's what's happening with mental health right now. Companies are coming, there's a ton of money, well there was, now the capital markets is seized, as we all know, but there was a ton of money coming in, and these companies now are running out of, just running out of runway, right? So there was a company, I won't say who it is, but I was so bullish on. It was diversity, it was a diverse network of providers, went out of business. Why? Because the CEO lost focus. He lost focus on what his mission was. Right, and so I just think in this day and age, if you're not focused, I know these guys all are because I talk to them all the time. But if you're not focused, it's there's no more money to have right now. Now maybe in 24 it opens up, the capital markets open up, but I just think you've got to be super focused on what your mission is and be focused on that and do that right. Otherwise, the Pear, 4 or 5 other companies, it's 10 years ago with wellness. It's it's all gonna bottom out.
It was our mantra.
That was very crass.
No, it was our mantra.
I love the fact, by the way, I love the fact that there's so much innovation in this space. It's amazing. Yeah, please. I'm trying to get, conversation going.
I also wanted to speak to the provider view of not being able to get clinicians to do things differently. It's very true, I have to say. It's very hard to get doctors, any type of frontline provider to do things differently. But think about it, I'll just give you a typical day in the life of a neonatologist. We, for a busy NICU, for example, I round on 60 babies. I'm the only attending. I probably have 2 to 3 minutes per baby to think about that patient. I have to talk to all the families. I have to do all my documentation. I have to supervise residents. I have to supervise fellows. I have to somehow squeeze in feeding myself, which doesn't usually happen. And then if I have a baby, I'm pumping, every 2 to 3 hours. Okay, so imagine that working 80 to 100 hours a week. So the healthcare system is asking more and more and more of us, which is why so many doctors are leaving the field, which is extremely scary, I have to say, because who's going to take care of us when we're old? And we're being asked to do more and more and more. And so when you're thinking about interventions that involve clinician behavior, think about how you can take work off of our plates, how to make our jobs more efficient, how to address a pain point. And so don't forget to talk to the doctors. Ask them what their struggles are, what their pain points are, and try to solve for those, because that's the only way that you're going to get clinicians to change their behavior.
Great question. question here.
Yeah, hi. More of an advice question. So there's a lot of kind of mental health issues within the academic setting. And I guess any advice on how do you get people to listen to you? So I've had a lot of trouble just getting my academic institution to listen to me, even when I provide data points on mental health being an issue within their graduate students and faculty. I guess any advice on how do you really get people to listen to you about those issues?
Yeah, I'll start. So when we first got into the autism space before it was in vogue, one of the hardest things was convincing the academic side of the field that taking a technology-driven approach made sense. And they very much took the view that only a board-certified behavioral therapist is equipped to deliver behavioral intervention. Stop. You can't train a caregiver, whether it's an educator, someone in the home, a junior therapist. And it took a lot of time and a lot of convincing to show and say, hey, if you take that model, you have maybe 35,000 BCBAs, 40,000 in the United States. You've got tens of millions of individuals with an autism diagnosis, hundreds if you look globally. So it's simply not scalable. You're never going to be able to deploy these individuals to solve the issue. So the only thing I would say is it took us several years and interfacing and talking to people, at all levels of academia, including the BACB, the board that governs behavioral therapy, to emphasize without technology, without tools in the hands of whoever, you're never going to replicate exactly. The clinical efficacy is never going to be, on a comparable level, but at least you're doing something, and that's better than nothing. So, but it takes time.
So I guess I wanted to build on something Jessica and Jon said. Trip, is your head is still connected to your body. So I work for a large healthcare system where you have a lot of acute care hospitals in urban settings, and you also have a large behavioral health network. I would say 50% of the people that are admitted into the ED have a dual diagnosis. And so to your point, Jessica, you're a clinician from both the medical side. I'm trying to understand if Daniel, any of your products address that dual diagnosis, and that's a very serious issue.
Absolutely. So I wholeheartedly believe in integrating behavioral health services into our current healthcare system. And marrying the body with the head. And so that is our business model. We basically, we are solving a pain point for obstetricians. They are tasked with screening for postpartum depression, and they have nowhere to send their patients. Literally, OB after OB after OB tells me, I'm really hesitant to screen because I've literally no therapists. The wait list for a therapist is 6 to 12 months long. And if you're pregnant, pregnancy lasts 9 months, and it's a little too long to wait. So so we are integrating those services into the current healthcare system. I think to reimagine the whole system is difficult. So we're addressing it by just simply placing those services at the clinician's fingertips. So that's one way to do it. There are multiple other ways to do it, I'm sure, but that's sort of a low-hanging fruit in our field.
And I would just add to that too. It's a virtuous cycle in that by focusing on those chronic medical conditions, which are also come in tandem with a behavioral health condition. If all you're doing is focusing on the behavioral health condition, it's harder to demonstrate value. Where if you actually focus on improving the physical health and the mental health together, you can wrap a nice, innovative pricing model on top of that and be able to bill an insurance company at a healthy premium for the value that you're going to create downstream, right? And that was kind of our secret sauce at Able To. That's what we built and ultimately sold to United, because we could demonstrate at scale when we intervened. Not only did we help manage the behavioral health side, but we also kept them out of the ER. We kept them on their meds and all of that good stuff. In the back, yeah.
Yeah, Trip, earlier you were talking about how our phones and social media is changing the way mental health looks, and I think as more and more people are getting more comfortable talking about mental health, there's been a rise in self-diagnosis as well. And I'm a therapy student, so I have some idea of what that looks like in the therapy room, but I'm curious about on kind of this higher end, how does self-diagnosis and the rise of more frequent self-diagnosis affect your jobs and your businesses, especially as it relates to autism and PTSD, which I feel like are seen pretty often when people are talking about self-diagnosis.
Yeah. So, Greg, good question. All right, so first, I want to respond to the woman who asked the question about this kids. Like, about talking about mental health. Like, just please talk about it. We're all leaders in this room. The number one effective way, like I go in front of a ton of payers and employers, and they're like, oh, I can change your mailer. It'll look like, I'll change it from black to green. It's like, blech, right? What actually impacts is when a leader talks about their own thing. And John and I know this, I'm allowed to talk about this. So Karen Lynch, who runs Aetna, suffers from mental health, and she talks about it. And when we first started able to, she did not talk about it. But she started talking about 5 years ago, and it changed the landscape of mental health. This is the thing. I challenge all of you in this room. We're all leaders here. Talk about it. Just talk about it. Because that unto itself will help others address it. Point two, to your question. So I was presenting in Florida the other day. It's so funny you asked the question. And there were like two very well-dressed professionals in front of me. I'm like, oh my gosh, these are doctors. And they're going to ask me about self-diagnosis. I know it. And they did. So here's the problem with self-diagnosis. By the way, it's both ways. So what they said, so he was the chief of psychiatric medicine at the Mayo Clinic in Jacksonville. And what he told me was like, Trip, 50% of my time is spent trying to tell people they do not have ADHD because they self-diagnose. And they walk in my office and they clog my system, right? Now, the other 50%, by the way, and I will admit this, is spending time faxing stuff, fax. And we know what fax is here? Faxing stuff to me for prior authorization, which is a joke. So we'll talk about that later. But anyways, but think about that, right? So they're self-diagnosing, and his point is like, I don't have the time to tell someone they do not have ADHD. Now, so this is a little bit of a paradox, right? Because I want people to talk about it, but yet his point was like, Trip, when they start talking about it, they self-diagnose, and they're in my clinic, and I actually have to support other people. So what I would also say, and I'll let panelists, to comment on this, is that like we have got to figure out how people can talk about mental health, but not have to see a psychiatrist, with all due respect, right? But see maybe a coach or a therapist or someone that's a lower lower clinical, degree, appropriately. So I'll give you an example. In Massachusetts, Reliant Healthcare is in Worcester, Mass. But no, Worcester is around here. So Sam Norberg, he runs a system in Massachusetts, in Worcester. He's got 1,000 patient backlog, 6 months. 6 months backlog to see a psychiatrist. He says to me, he's like, Trip, you know what? 75% of those patients do not need to see a psychiatrist. That's him. He's a clinician. I'm not a clinician. He's a clinician. He's like, they need to see like a coach or like a diagnostic therapy tool. They could be fine with that. But the problem is you got stigma on stigma, which is like when I convince my neighbor, for example, that he needs help, he's like, well, I need to see a psychiatrist. I'm like, you don't need to see a psychiatrist. You can see a coach, and that's fine. So, but the problem is like, how do you then get people to lower levels of care when it's clinically appropriate next to a doctor? I don't want to offend, right? But seriously, right? Like, because I firmly believe this too in mental health. There are not enough human beings on this earth to support the supply. Right? There are not enough doctors. It's not going to happen. So you have to find other levels of care. And that's why companies like this are so important, because they're trying to find other modalities to support patients. Now, I'm going to, if you don't mind, I'm going to put you on the spot.
No, thank you for the question. And also just going back to the last one too about academia and like how you talk about this. I mean, one thing I've been in academia a long time. I think it depends on your institution too, right? And like their receptivity to it. And like, again, going back to stigma, I think also it can be really helpful to like speak about it in a group or like send something where like one person isn't necessarily like the the leader, right? Because you don't want to be targeted too. But I also think it depends on how you frame the asks, because I think that, just in leaders in general, right? You want to call them in, not necessarily like call them fully out. Does that make sense? So I think there's like a way to do it that feels like still like you're all on the same team. You're bringing up something that like, and surfacing something that, they haven't thought about before. And it's a group of you doing it. It's still a community. And then going back to the other question too about self-diagnosis. I mean, like, I obviously see this all the time, right, as a psychiatrist too. And I mean, I think people self-diagnose. There's two things actually. There's stigma and there's quality of information, right, that's out there. And people self-diagnose because they're searching for something, right? They think that there's something wrong with them and they don't know what it is. And they're looking on TikTok. Or they're going to like Dr. Google. And the problem with mental health is that the quality of the information that's out there is also very low, right? And like, and then also unfortunately too, the quality of like clinicians that you see is pretty wide sometimes too. And so it's really hard to know who to trust. And so I think another opportunity for startups like ours too is providing that honestly, like frankly, like free psychoeducation and like information out there, like putting out stuff that's like more trustworthy too, so that people know there are sources to trust that aren't necessarily like doing a 90-minute eval with a psychiatrist.
I also wanted to add that going back to this theme of data is gold, data is how you convince people at the health systems level, leadership, clinicians. So the only way that besides taking work off of our shoulders, the other way to convince clinicians is by, peer-reviewed, evidence-based articles that show that your intervention works. That is those two things. If you can get those two things, you'll have an intervention that will make an impact in healthcare. I, as a non-behavioral health clinician, I'm trying to convince people that coaches are valuable and can help new moms, and is what new moms want to talk to a peer. They want to talk to a mom, but it's got to be not a Dr. Google mom, but a well-trained mom who has, anybody can be a coach with a certificate online. So we're trying to elevate the quality of coaching and show in data, in evidence that it works. And so if you can bring cost data to the table, if you can bring clinical data, and it doesn't have to be the highest quality data, just bring some numbers to the table to convince your audience.
Let me also add, I 100% agree with you, Trip. There is a place for self-directed care, and I think if you look at what employers are doing today, to your point, there's a whole slew of technology out there that allows for self-directed learning. I mean, a lot of our model is based on that. But you have companies like Ginger, Calm, we do that in an employer space at Rethink as well, giving tools to an employee that may be feeling depressed, maybe anxious, certainly does not need psychiatric intervention, but they can learn how to address some of those issues on their own. And if it's not solvable, then you elevate it to a medical professional. So those things do exist. I think it is incumbent upon employers to get the word out. And I think the nice thing here is there's no stigma associated with that because it's all anonymous. You log on, you're on your phone, and you can learn on how to address some of your own issues. So the nice thing is, I think to your earlier question, a lot of the tools that didn't exist before COVID, now you have a plethora of solutions that are available. And I think most employers today offer some form or other.
Thank you, panel. John, question over here on the left.
Yeah, I'm just kind of curious, what is the state of, AI driven, you talk about triaging. What's the state of that for triaging and deciding who does need to see a counselor or get treatment compared to, and then you can get rid of all those people who are just self-diagnosing with ADD.
Yeah, I'm happy to take that. I mean, we see a lot of amazing new solutions in that space almost on a daily or weekly basis. And I think we're bullish about those types of opportunities. But again, for me, I hate saying it, I feel like a broken record sometimes, but it's about the reimbursement pathways. Like how do we get paid for those tools? How do we package it or bundle it with other services so that you can cover the cost? And for those companies, how can they operate at a margin that makes sense for them? Right, so it's another intuitive one where we know there are tools that can do it better. We just have to figure out the business model behind it.
Yeah, Jonathan.
Yeah, I think we have a...
Yeah, I'll be brief. So I think, so with AI, there's many dimensions you can use it. So for example, there is absolutely no reason why a provider should not be paid smartly, right? So like, let's walk it way back. Forget like counseling. This is like, how do you pay someone the right amount of money on time, right? And within their fee schedule, which we do terribly in behavioral health. And I do it very badly, just so everyone knows. I'll admit that, right? But we do it very badly. So you can use AI for that, right? I think in general, though, and I, again, invite your opinions on this, we are behind physical health in mental health with AI. Now, there was another article, I think in the Wall Street Journal, that was scathing about AI. Like they did a couple like investigative pieces, and the AI actually encouraged someone to jump off a bridge at the end of the treatment session, right? I mean, again, like, okay, fine. So pause. Like, let's figure out like how to make this. Obviously, that's not the outcome we want, right? But the fact is, like, we have to use this smartly. And behavioral health, I think, can benefit from it. But let's start with the basics. Like, pay providers on time the right amount of money, and AI can do that in a heartbeat. In a heartbeat. And so I just think we use it that way, and then we progress naturally to get to a point where, like, I mean, again, like I'll ask the panelists, but like, do you guys believe like chat?